This opportunity. I thank the organizer for this. And I'm also very fortunate to be here physically at the meeting. So I'll be talking on breakthroughs in lymphoma. So let's start with breakthroughs in Hodgkin lymphoma. It's been the conventional ABVD for the last 3 decades, and here's the Echelon-1 trial, which was an international randomized open-label phase 3 trial, which included patients with newly diagnosed advanced Hodgkin lymphoma. Good number, more than 1,300 patients, randomized to brentuximab plus AVD versus ABVD 6 cycles, and the primary endpoint was a modified PFS. And here you can see that there was a 5% benefit in the modified PFS in the, favoring the brentuximab arm as compared to the ABVD arm. And though the side effects of grade 3 and grade 4 side effects were a little higher, and including hospitalizations were a little higher in the brentuximab arm. And a recent update which was presented recently of the same trial, you can see that the 3-year PFS, there was a sustained benefit in the brentuximab arm as compared to the ABVD arm. So this is FDA approved for the treatment of advanced untreated classical Hodgkin lymphoma. So this is a very interesting trial, which I consider this as one of the breakthroughs, brentuximab and nivolumab for patients with relapsed refractory Hodgkin lymphoma, a 2-year update. So 93 patients were enrolled. You can see the very good impressive overall response rate of 85%, complete response rate of 67%. And you can see that 67 patients went on to undergo autologous stem cell transplantation, and very good PFS benefit of 91% at the end of 2 years. So this, I would definitely consider this as one of the important regimens in relapsed refractory Hodgkin lymphoma. A similar trial, but this was in young adults and adolescent patients, 5 to 30 years of age group, the CD30 positive classical Hodgkin lymphoma, relapsed refractory. Patients were given nivolumab plus BV, and who did not have a partial metabolic response or who did not have a complete metabolic response, they went on to get intensification with BV plus bendamustine, and then went on to undergo stem cell transplantation. You can see that here again, a complete metabolic response of close to 88%. And that's phenomenal, and you can see that 1-year PFS rate of 91%, and the median duration of response was not reached. Again, a very good regimen to follow in relapsed refractory setting. This, I think most of us know that post-autologous stem cell transplantation in relapsed Hodgkin lymphoma, patients were randomized to brentuximab for 1 year versus placebo. And you can see that the recent results, the update was presented by Maskowitz et al. And you can see that the 5-year PFS was 59% favoring the BV arm as compared to 41% with placebo. Very good hazard ratio of 0.5 to 1. So definitely brentuximab as a maintenance is the way to go. And again, phase 2 Nivo, I chose this study to be there as one of the breakthroughs because post-BV, post-auto, is where you give single agent Nivo, you can see that patients continue to have a prolonged PFS and prolonged duration of response. So this is something which is again here to stay. So the Keynote 204 trial, again, patients with relapsed refractory Hodgkin lymphoma randomized to Pembro versus brentuximab vedotin presented in ASCO 2020. Again, early results, but again favoring the Pembro arm. This is one such trial which has actually been compared to BV. I think I'm sure going forward, several immune checkpoint inhibitors will be compared to BV. So coming to breakthroughs in follicular lymphoma, this is something which is a very important prognostic indicator. Early progression of disease as a predictor of overall survival in patients with untreated follicular lymphoma. Good number, close to 1,400 patients from different cohorts, grade 1 to 3A of follicular lymphoma. The 5-year survival in patients who progressed after 24 months was equivalent to the background general population. And those who progressed early, you can see that there's dismal survival. This, again, is a very important prognostic indicator. Again, we know the conventional FLIPI and other mutated genes, the 7 genes have been incorporated in this FLIPI, and then the ECOG performance status has also been incorporated. Based on this, they have arrived at a very accurate model to predict the prognosis in follicular lymphoma. This is called as the M7 FLIPI. Going to the Gallium trial, again, it's been rituximab all this time, but here this is the patients with untreated indolent non-Hodgkin's lymphoma, randomized to obinutuzumab plus chemotherapy versus rituximab plus chemotherapy, followed by obinutuzumab or rituximab maintenance. You can see here that there was a 3-year PFS benefit of close to 7% in the obinutuzumab arm. Of course, there was no OS benefit, but in follicular lymphoma, PFS is also as important, what we say. And coming to the chemo-free approach in follicular lymphoma, it's been RCVP, Benda, and rituximab. But now we have this rituximab plus lenalidomide, again, which was randomized to the R chemo. And here you can see that it was a non-inferiority trial. The R square was equivalent to the R chemo, both in terms of the PFS as well as the OS. Again, in the relapsed refractory setting of follicular lymphoma, lenalidomide and rituximab was compared to the rituximab plus placebo. Again, here you can see that there was a PFS benefit and OS benefit. So relapsed refractory setting, definitely R square is one of the regimens to follow. So this has been a recent breakthrough designation by FDA. You can see that tazemetostat is an EZH2 inhibitor, and you can see here early studies, but patients who had mutation of EZH2, there was a 100% response rate, and you can also see that there is a PFS benefit as compared to the wild type, where it was 71% response rate. So tazemetostat has been FDA approved recently for patients with follicular lymphoma with EZH2 mutation status, but only in the relapse setting. So we've been talking a lot about IV therapies. Again, subcutaneous rituximab, which has become a standard of care in the United States now. Untreated follicular lymphomas, we have the Sabrina trial, and then we have the MABES trial, which looked at subcutaneous rituximab in the DLBCL patients. So both these were non-inferiority trials, and both these trials have proved that subcutaneous rituximab is non-inferiority to IV rituximab. Again, this is FDA approved for newly diagnosed and relapsed refractory DLBCL, follicular, and CLL. So breakthroughs in DLBCL, I think we also talked about this de-escalation strategies, very early stage, good IPI score, DLBCL patients, no bulky disease, 4 cycles of R-CHOP followed by 2 cycles of rituximab, randomized to 6 cycles of R-CHOP. You can see that again at 36 months, the PFS and OS has been quite similar. The REMARK trial looked at elderly patients to see if this lenalidomide maintenance would be of any use. And you can see that there was a PFS benefit in patients with GCB as compared to the non-GCB, of course, with a certain amount of added toxicity like neutropenia and certain amount of discontinuation. This was a very interesting trial where they looked at rituximab, lenalidomide, and ibrutinib in patients with non-GCB or DLBCL newly diagnosed, 2 cycles followed by randomization to continuation of R, L, and I, and either the patient would receive R-CHOP or EPOC. And you can see that almost 50% of the patients had a very poor IPI. High Ki67 was included in several of the patients, and double expressor was seen in 54% of the patients. And you can see at the end of 1 year, very early results, median PFS was not reached, median OS was not reached, but very good PFS rates and OS rates. And coming to polatuzumab, this has been combined with bendamustine and rituximab, and compared to the standard of care bendamustine and rituximab in relapse setting. I wouldn't say standard of care, probably BR has not been used a lot in DLBCL, but this was compared to the BR. And you can see here that 78 patients were included. The CR rates were better in the polatuzumab arm. And you can see that the PFS and OS benefit, again, early results, but definitely favoring the polatuzumab arm. So again, this has got accelerated approval by FDA for relapsed DLBCL for patients who have received at least 2 lines of therapy in combination with bendamustine and rituximab. Coming to this primary mediastinal B-cell lymphoma, we all use dose-adjusted EPOCH-R a lot, but those who relapse, again, this Keynote 013 and the Keynote 170 trials have looked at the role of pembrolizumab, and you can see that the overall response rates have been close to 50%. The PFS rates at 12%, at 12 months has been close to 50%, and you can see that the OS has been around 65% in these patients. So again, this is approved in patients with relapsed refractory primary mediastinal B-cell lymphoma recently. So breakthroughs in mantle cell, again, there are plenty of trials, but I thought this is a very interesting trial, the window trial, a window of opportunity to avoid initial chemotherapy. So what they did, very interesting plan, using ibrutinib and rituximab, 2 cycles, and then if the patient goes into CR, use 4 cycles of hyper-CVAD. If the patient has a partial response, a stable disease, continue with ibrutinib and rituximab for 2 more cycles, and then go. If the patient has a CR, go on to plan B, that is hyper-CVAD. If the patient has progressive disease, go on to plan B, that is using more of chemo. And you can see that the overall response rate was 100%, 50 patients, 100% overall response rate, CR of 92%, very good, impressive results from our MD Anderson colleagues. And you can see that irrespective of the Ki67, the patients did extremely well. So in blastoid, as you know, 30% Ki67 or more is considered as actually high risk. Coming to T-cell lymphoma has been chopped all the way over the last 30 to 40 years, but this is something which came recently, the Echelon-2 trial, which looked at CD30 positive T-cell lymphomas, untreated patients. Good number, 452 patients, but 70% of the patients included only systemic ALCL. So this study was not powered to look at other histologies. So the patients were randomized to BV plus CHP, and in the other arm, it was the conventional CHOP. And you can see that the progression-free survival was a mammoth 28 months more in the BV arm. And you can see that in both the arms, the OS has not been reached, but you can see the hazard ratio of the OS, that is also, I think it was 0.65. So this goes to say that there's a PFS benefit and OS benefit in patients with CD30 positive T-cell lymphomas, and this is definitely an important breakthrough in T-cell lymphomas where we are struggling to treat and patients relapse very soon. To summarize, the role of brentuximab vedotin and immune checkpoint inhibitors, including nivolumab and pembrolizumab, has significantly evolved in classical Hodgkin lymphoma. Progression of disease at 24 months in follicular lymphoma, and the M7 FLIPI prognosticate patients better in follicular lymphoma. De-escalation of R-CHOP in favorable risk early stage DLBCL can be considered. Role of lenalidomide and ibrutinib is evolving in newly diagnosed high-risk DLBCL. Polatuzumab vedotin in relapsed refractory DLBCL is another promising regimen in combination with bendamustine and rituximab. Pembrolizumab in relapsed refractory primary mediastinal B-cell lymphoma, again promising results based on the Keynote 013 and the Keynote 170 trials. This is here to stay. And the role of ibrutinib and acalabrutinib, for want of time, I couldn't talk about acalabrutinib, but it's a wonderful molecule like the previous speaker spoke about. It's evolving in mantle cell lymphoma along with CLL. And brentuximab vedotin in combination with chemo, that's CHP, in untreated CD30 positive T-cell lymphomas, excellent PFS benefit, and definitely this is the future for T-cell lymphomas. Thank you so much for a patient hearing, and I would like to thank the organizers again for this wonderful opportunity.